We shall now go on to our next speaker, Dr. SUSMITA SHAH, who's a cornea and refractive consultant from iLife Khar and Netra Mandir, and she's going to be showing us some different kind of case scenarios which on corneal trauma. On to you, Dr. SUSMITA.
Good evening, everyone. I thank Chitra ma'am, Shreya ma'am, and the esteemed ARC for this opportunity. So moving on from these brilliant didactic talks which my previous speakers have presented, I will be presenting a few case situations which describe the unique sequelae that you may come across following cornea and ocular surface in trauma. So my first case is this 13-year-old child who presented to us sometime around 2013 with history of Lyme injury about 2 weeks before. Now, as you can see, there is a dense deposition of calcituna in the cornea, and there is extensive loss of the ocular surface epithelium involving the tarsal surface, the bulbar surface, the corneal surface, etc. So what we did was we excised the Lyme deposits in the superior part of the cornea and replaced it with a lamellar patch graft, not a full thickness graft, but a patch graft, and covered the entire surface with amniotic membrane. Now, this is post-op about 5.5 months. We can see limbal stem cell deficiency and with some amount of symblepharon, but even at this point, she had about 6/60 vision. Unfortunately, she was lost to follow-up after this and came back more than a year later with a visual acuity of 6/60 with symblepharon with an obvious limbal stem cell deficiency. So we planned a simple limbal epithelial transplantation or the SLET procedure along with the conjunctival autograft for the symblepharon. As you are aware, the SLET is now the treatment of choice for all eyes with unilateral limbal stem cell deficiency. And this is the post-op follow-up after the SLET. As you can see, the limbal biopsy well in place, and there's a bandage contact lens. Unfortunately, we again lost follow-up of this child 3 months post the SLET procedure, when she presented to us 6 years later with again a best-corrected visual acuity of 6/60, partial LSCD, symblepharon, both superiorly and inferiorly. So to rehabilitate her, we planned symblepharon release with amniotic membrane grafting, conjunctival autografting, and an anterior lamellar keratoplasty. So because of the symblepharon, we are unable to put the speculum. So we put lid sutures and retracted the lids. This is the inferior symblepharon, which we are currently excising. And this is the upper lid. We have excised the superior symblepharon. This is the undersurface of the upper lid. This is fibrin glue being put on the tarsal surface, and we are fixing an amniotic membrane there. Now we take a conjunctival autograft from the bulbar conjunctiva involving the nasal part of the eye, and as we know, the symblepharon has to be replaced with the conjunctival autograft. If you just put an amniotic membrane, it does not work. So putting the conjunctival autograft in the superior bulbar conjunctiva. The inferior symblepharon is covered with the conjunctival autograft also from the bulbar surface. Now this is the bare surface of the sclera, which is being covered from where we took the graft. We are covering it with the amniotic membrane. Next is the anterior lamellar keratoplasty. We're trying to put the dissector, and we thought maybe we might be able to induce a bubble, but because of the patch graft, pre-existing patch graft which was there, the bubble never happened. So we are going ahead and doing a lamellar dissection of the corneal tissue. So it's not really possible to do a DALC and expose the complete descemet membrane, but we could always go to the pre-descemetic space, and therefore we planned this interlamellar keratoplasty. This is the patch graft which is now currently being excised, and that's the donor corneal tissue, which is from which the descemet and the endothelium has been removed, and now we are doing 16 sutures, and we have secured the graft. This is the post-op 6 months. Now our visual acuity has improved to 6/18 N6 with a clear graft and a very well maintained ocular surface. Both fornices were well formed except for a small symblepharon in the inferior fornix. The anterior segment OCT is extremely interesting here, as you can see, the crystal clear stroma, and there is a very nice epithelium that you can see. So this essentially indicates the establishment of the limbus in spite of such severe chemical injury, and we can see a mild amount of corneal tissue still there on top of the descemet membrane, which again points that this was not a deep anterolamellar keratoplasty, but an anterolamellar keratoplasty, and the surface, as you can see, even with the fluorescent staining, it is very well maintained. So this kind of concludes as a successful outcome in this severe chemical injury. So limbal stem cell deficiency, or which is also the LSCD, and abnormal ocular surface are known sequelae of the chemical injuries, and we may often need multiple stage procedures to obtain a stable ocular surface and provide visual rehabilitation to the patients. Dr. Maskati sir is covering the chemical injury, shall not go in details of this. Move on to the next situation. This was a young 32-year-old male who was referred to us with complaints of a white spot in his right eye of 2 months duration. He had an unaided visual acuity of 6, 6, and 6. And on slit lamp evaluation, we found a white cystic lesion near the 11 o'clock limbus with conjunctival override. And the lesion contained whitish fluid, which was found to be pre-descemetic in location on the anterior segment OCT. Looking at his past history, which was, we retrieved his past records and found that he had presented earlier with a history of trauma about 6 months back. And he had a lamellar corneal tear, which was extending from the limbus at 11 o'clock with an foreign body impacted within the lips of the corneal tear. The foreign body was removed and he was treated with topical antibiotics. No surgical intervention was done. Hence, we came to the diagnosis that this was a traumatic intracorneal epithelial cyst. And the management option here was very tricky, as the patient had an uncorrected visual acuity of 6 by 6 and 6, but he was concerned about the look of that white spot in his eye. And also there was a possibility of this cyst increasing in size and coming into the visual acuity, in which case it could have caused scarring and loss of vision. So we had to plan something which is minimally invasive and to remove the cyst. Also, simple aspiration of the cyst is known to cause recurrences. So the other options include aspiration of the cyst contents along with cauterization of the cyst using either 96% ethanol or 20% trichloroacetic acid. The other options include excision and drainage, which would have been very invasive. Keratoplasty is usually reserved for recurrent cases and is also a very invasive technique. So we planned a cyst aspiration with chemical cauterization using ethanol under local anesthesia. Then we came across literature which mentions that single application of ethanol can cause recurrence of the cyst. So we planned multiple applications of ethanol within the same sitting. So here is the video. So the localized conjunctival peritomy is done to look for any occult scleral tear. We debride the corneal epithelium with a 15-number blade. Now that's the pre-existing corneal tear. It has been identified. A 26 gauge needle, 30 gauge needle is inserted and the cyst contents are aspirated out. Then this is 96% ethanol is injected into the cyst cavity and it is kept for 1 minute. At the end of 1 minute, it is replaced with distilled water and the process is repeated thrice. The tear is then sutured using 10-0 nylon sutures. And sutures are buried. So this is the post-op follow-up. The top left picture was the early post-op. As you can see, a resolving cyst even noted also on the anterior segment OCT. The right photograph is the late post-op. We have now more than almost 36 months follow-up. He has a small refractive error of 0.5 cylinder at 90 degrees, but he is maintaining at 6 by 6 and 6, and we still don't have any recurrence. So penetrating or perforating corneal tears may lead to implantation of epithelial cells deep into the corneal stroma, especially if it is located at the limbus. These cells may proliferate to give rise to intercorneal epithelial cysts. Leaving lamellar tears unsutured may lead to increased chances of such complications, and therefore lamellar tears should be sutured. Ashish has also highlighted that point beautifully. Intracorneal epithelial cysts may be effectively managed in a minimally invasive way by cauterization with 96% ethanol, followed by distilled water, leading to attenuation of cyst and no recurrence. What we did differently here was 3 applications of ethanol instead of 1 to prevent recurrence. Coming to my last case, this was a 36-year-old male factory worker who was referred to us with complaints of decreased vision and glare. Now he had suffered a corneal tear while working about 8 months back, and my referring colleague had done a very good corneal tear repair along with an iris abscission. And thereafter, a suture removal was also done. Now, when he presented to us, his uncorrected visual acuity was just counting finger 3 meters, and his best corrected visual acuity with a refractive error of plus 2.50 and minus 8 diopter cylinder at 9 degrees. His vision was improving to 6/9 parts and N6, and he was 6/6 and 6 in the other eye, and he refused to wear glasses. And on slit lamp examination, as you can see in the photograph, there was a healed, there was a sutured corneal tear with an underlying iris defect. So these are the topography. As you can see, very steep cornea, overlying the area where the scar is, and the anterior segment OCT. Here again, you can see very nicely a post-corneal wound by my referring colleague, and how nicely the both edges of the cornea are well opposed. Now, this patient vehemently refused a contact lens trial, so he wanted a surgical management of his problem. So we planned an iridoplasty using the modified Sixer knot, followed by a topography guided PRK and mitomycin C under topical anesthesia. This is the video of the modified Sixer knot. It's a different case, not this case. So what we do is we made a side port entry, inject pilocarpine, constrict the pupil, then inject viscoelastic. And this is a 9-O-proline suture, which is passed through the torn edges of the iris, and it is taken out through the cornea. And it's to be very clear in eyes which are phakic that the swage of the needle does not touch the anterior lens capsule. You can do it much more comfortably if it is a phakic or a pseudophakic eye. Now the equivalent hook is introduced, the suture is pulled out to make a loop, and we have the trailing edge of the suture pass through the loop 3 times. And then we pull both ends of the suture to oppose the knot. The same thing is repeated 3 times to make a knot, which is in a 3-2-1 fashion. And then this was followed about 6 weeks later by topography guided PRK. As I had mentioned, he had a refractive error of plus 2.5 with a minus 8 diopter cylinder. The machine can correct only up to minus 6. So that is what we corrected. And an ablation depth of around 158 micron was done, and the residual bed thickness was about more than 352 microns. So this is the final follow-up photograph. This is about 3 months. We can see a much more regularized topography, and the iris defect has also been sutured, so he has no symptoms of glare also, and his uncorrected visual acuity now is 6/12 and 6, and he's pretty happy and rehabilitated. So to summarize, anterior segment reconstruction and visual rehabilitation may still remain a challenge following a good primary repair of corneal wounds, and contact lens as well as laser vision correction may be an effective modality. Thank you so much.
Oh, that they were very diverse, wonderful cases and very impressive. And I request Dr. Quresh Muscati and Ashish to discuss the 2 first 2 cases.
Yeah, excellent work. Both the cases brought out a lot of take-home message, and SUSMITA gave all those take-home messages.
Yeah.
So there are many ways to skin a cat, and all these have to be tackled on an individual basis because all traumas are different. No one trauma is like the second trauma, but all excellently done, SUSMITA.
Thank you, sir.
Any point for discussion? Dr. Ashish? Dr. Ashish, are you there?
No.
Sorry, ma'am, I got disconnected.
Yeah.
No.
Did you
The last
watch?
question.
Oh, you couldn't watch her cases?
No, I missed them. I missed it.
Oh, okay, Dr. Shreya, you have anything to ask? Dr. Quresh can answer and Sushmita can.
Nothing. No, I don't have to ask anything. I think I just wanted to ask Dr. Sushmita, other than this topic, do you have any experience of tin and patch graft using for trauma cases?
Once, patch graft. No, ma'am, I have not used it for any trauma cases as of now. It is usually for perforations and melt. But I presume, like what Purendra sir was also mentioning, that sometimes in this tri-radiate tear, when you have if you have a small area where you are not able to seal it, it might, tin and patch graft might be an option if you do not have a cyanoacrylate handy in your OR. A very small bit of tinons might be good. Tinons, it gets integrated very beautifully with the cornea. Now I've recently published on paper also on that where we had to put a tinon and do a penetrating keratoplasty after that. And when we evaluated the corneal button, we found how beautifully the tinon can integrate into the corneal stroma. So I think it's a good idea if you do not have cyanoacrylate and you have a wound which is still leaking and you're not able to close it in spite of a lot of sutures, then possibly yes.
Thank you. Any question, Dr. Maskati? If you
No, I'm fine. Yeah.
Yeah.
Dr. Ashish? Okay. Thank you.
Thank you. Thank you, Sushmita. Very interesting cases, all of
Thank
them.
you.